Hi, my name is Professor Steve Fink, and this is the third video in this series reviewing medications taken by dental patients for the RDHAP training program. Hopefully, you've already watched the first video in the series on medication use in elderly dental patients, although not limited to the elderly. And you've also hopefully watched the second video in this series on autonomic drugs, because that gave you the background to understand many of the medications that are used for this unit on cardiovascular diseases and cardiovascular medications that patients take. Among the most common diseases there are heart disease and high blood pressure. And so in this unit, we're going to cover cardiovascular diseases and drugs broadly. So we'll take a look at our lecture outline, and you might wish to print out this lecture outline. So cardiovascular diseases include coronary artery disease, which is also abbreviated as CAD. It's also known as coronary heart disease, CHD, myocardial infarction, which is the clinical word for heart attack, congestive heart failure, which is associated with decreased cardiac output by the heart and a failing heart, and atrial fibrillation, or AFib, which is an arrhythmia, an electrical arrhythmia of the heart that leads to blood clotting problems. Heart disease is the leading cause of death in both men and women, accounting for 25% of all deaths. So it is the #1 cause of death. What we've indicated next are the common signs and symptoms that somebody has heart problems, including myocardial ischemia or angina pectoris, as well as a myocardial infarction or heart attack. And this includes chest and the pain, pain in the jaw, the neck, even in the back. You can look at all these bullet points. I'm not going to read all of them. Nausea and vomiting, swelling of veins in the neck are all indicators of possible cardiac episode. Risk factors for heart disease include a history of high blood pressure, elevated cholesterol levels, and a history of diabetes. Commonly, all three of these go together. They're known as metabolic syndrome. Also, a risk factor is inactivity, physical inactivity, not getting enough regular exercise, not eating properly. Also, a family history of cardiovascular illness or disease. Increasing age. As we grow older, we are more prone to cardiovascular problems. Among the blood tests, an elevated C-reactive protein, which indicates inflammation in general, including inflammation of blood vessels, sleep apnea, stress, and for women who experience preeclampsia, which is elevated blood pressure during pregnancy, so they are at increased risk of developing cardiovascular problems as they grow older. Scrolling down, oral health considerations for heart disease. These guidelines, I believe, are consonant with the guidelines that you've heard in your other training courses. A patient should wait 3 to 6 months after they've had a myocardial infarction before having seeing the dentist or dental hygienist. All of the following should be under control. Their blood pressure. If they've got blood pressure medication for high blood pressure, they should be taking it. Medication for angina pectoris, heart failure, and heart arrhythmias. All of that should be under control. And of course, it would be valuable perhaps to check with their doctor to confirm. Patients may need to be seated in a semi-supine or upright position because many antihypertensive drugs taken for high blood pressure create a condition of postural hypotension or orthostatic hypotension, where the person tends to feel faint upon going from a reclining position to an upright position quickly. If the patient is taking blood thinners, specifically Coumadin, warfarin, they should have an INR an international normalized ratio of 3.5 or less. We will talk more about all of these and what they mean if you're not familiar with these in other videos. If they are taking a blood thinner, it is not necessary. In fact, they should not discontinue the use of their blood thinner prior to a dental appointment. It is safe to give up to 2 cartridges of 2% lidocaine with a 1 to 100,000 epinephrine. The concern here is epinephrine itself. If it were injected into the bloodstream, which it should not be, but it could potentially have some stimulating excitatory effect on the heart and speed up heart rate and increase blood pressure. Not likely, but could, and you're not going to inject it into the bloodstream anyhow. An alternative is to use a 3% or 4% bupivacaine, which has no epinephrine in it. Some of the medications that patients are taking for heart disease has adverse or side effects of causing dysgeusia, change in taste in their mouth, also promoting stomatitis, gingival bleeding, petechiae, xerostomia, and lichenoid lesions, among other things. We've given you the guidelines here for high blood pressure. So right now, if the patient has a systolic of 120 to 139, that's considered pre-hypertension. Once it reaches 140 or higher, that's outright high blood pressure. And with the diastolic, 80 to 89 is pre-hypertension. Once it reaches 90 or above, again, it's high blood pressure. We're going to go into systolic and diastolic and what all these things mean in another video. As I scroll down, the very first page of the lecture outline looks like this. I've reproduced it because in the video that you're going to watch, I try to describe the connection between atherosclerosis, increasing the risk of ischemia in different tissues and organs of the body, increasing the relationship of atherosclerosis to raising blood pressure and increasing the workload on the heart, leading to heart failure, and atherosclerosis increasing the risk of blood clotting, leading to a myocardial infarction or cerebrovascular accident. The rest of the lecture outline is available at the very, very bottom. Let me continue to scroll. So these are videos where I expand. These are actually videos that were taken when I gave lectures in my classroom, covering the statin drugs and blood thinners that are used to control angina pectoris and blood clotting risks, anti-anginal drugs, antihypertensive drugs, and digitalis and cardiac antiarrhythmic drugs. If you click right here where it says cardiovascular drugs, number 5 cardiovascular drugs PDF, you can download the complete lecture outline that you'll see me making reference to in all of these videos. What I recommend that you do is you can go through those topics that you want to learn more about, skip those that you feel you already know. You can always speed through. I think you all know that when you're watching a YouTube video, and these are on YouTube, you can adjust the speed at which the video plays. So you can make me speak a lot faster and go through the video quicker. But we want to give you a review of these conditions, these disorders, and the most common medications your patients are taking and their adverse effects. All right, so that's the summary of this introduction to cardiovascular diseases and the medications that they are taking. So please watch those videos to help you learn more about the medications. And after you're done with reviewing cardiovascular drugs, the next topic that you should go to is on stroke. So that would be the next video covering stroke and the management, primarily using blood thinners to control and reduce risk of further strokes and other blood clotting issues. We'll see you in the next videos.